You can lose a lot of weight on either one. That is the easy part. The harder part is this. These two drugs are not competing on the same scoreboards. One has stronger average weight loss data in direct comparison, but both carry labeled indications that point in different directions, and which one matters depends entirely on the patient. So the real question is not just which one is better, it is better for what. This is not medical advice. Consult your doctor. Wegovy contains semaglutide. Zepbound contains tirzepatide. Both are once-weekly injections for chronic weight management, but they are not the same drug, and they are not interchangeable in any simplistic sense. Semaglutide works through GLP-1. Tirzepatide targets both GLP-1 and GIP. You do not need to memorize receptor biology for this video. The practical point is simpler. Same category, different biology, different strengths, different trade-offs. I'm Dr. Kim. Let's break down where Zepbound looks stronger, where Wegovy has a real edge, and how to think about the choice in practice. Weight loss. If your only question is average body weight reduction, Zepbound currently has the stronger case. In the head-to-head SURMOUNT-5 trial, Tirzepatide produced greater average weight loss than semaglutide over 72 weeks. That matters because this is not just a side-by-side comparison of separate studies anymore. We now have direct comparative data, but data alone does not make a decision, because medical decisions are usually ruined by a single word, only. If you ask only about average weight loss, you get one answer. But weight loss is not the only scoreboard. Wegovy has an FDA-approved indication to reduce the risk of major adverse cardiovascular events in adults with obesity or overweight who also have established cardiovascular disease. That is not a minor extra. In the right patient population, Wegovy is not just a weight loss drug in the regulatory sense, it also carries an outcomes-based cardiovascular label. Zepbound has an FDA-approved indication for moderate to severe obstructive sleep apnea in adults with obesity. That means, if the patient in front of you has obesity plus clinically important sleep apnea, Zepbound enters the conversation with a very specific advantage that Wegovy does not have. Not which one wins, but which problem are you trying to solve? If the answer is, I want the strongest average weight loss data, Zepbound looks stronger. If the answer is, I have obesity plus established cardiovascular disease, and that cardiovascular indication matters, Wegovy becomes much more interesting. And if sleep apnea is a major part of the picture, Zepbound becomes more compelling for a different reason. This is why comparison videos can get shallow very quickly. They often act like there is one scoreboard. There is not. Now, what about side effects? The short version is that both drugs live in the same unpleasant neighborhood. Nausea, vomiting, diarrhea, constipation, abdominal discomfort, and reduced appetite are all familiar here. Both use stepwise dose escalation because the GI system often needs time to adapt. So if someone asks, which one has side effects? The answer is both. If they ask, which one is easier to tolerate? The answer is less tidy, because how a person responds to dose escalation is heavily individual. Some patients move through dose escalation with minimal disruption. Others find the early weeks genuinely difficult, regardless of which drug they are on. What often determines whether someone stays on treatment is not just which drug they chose, but how the dose escalation is managed and whether they have realistic expectations going in. A patient who is warned about the first few weeks is in a much better position than one who is surprised by them. A drug can look stronger on paper and still be the wrong choice for a person who cannot stay on it. And a drug can look less powerful on average and still be the better long-term choice for someone who tolerates it well, responds steadily, and can actually continue it. Medicine loves nuance. Patients usually prefer a simpler answer. The tension between those two things keeps doctors employed. But even the most nuanced clinical decision can be overridden by something far less elegant. Now, let's talk about access, because real life has an annoying habit of interfering with elegant treatment plans. In practice, the best medication is often the one you can actually obtain, actually afford, and actually stay on. Insurance coverage matters, formularies matter, prior authorization matters, local availability matters. This is one reason online comparison debates can become detached from reality. They often assume identical access, identical insurance, and identical pharmacy supply. That is not how any of this works. A theoretically perfect choice is less impressive when it takes 3 appeals, 2 denials, and 1 emotional support email to your insurer. A drug you cannot keep getting is not a long-term plan. It is a stressful hobby. Supply disruptions affected both medications in the past, and while those shortages have since resolved, access barriers have not disappeared entirely. Insurance coverage, formulary restrictions, and dose availability still vary enough in practice that the drug you can actually get, at the dose you need, may not always be the one that looked best on paper. Should someone switch from Wegovy to Zepbound just because Zepbound looks stronger on average? Not automatically. If someone is already doing well on Wegovy, tolerating it, losing meaningful weight, and has reason to care about the cardiovascular indication, the answer is not automatically switch. On the other hand, if weight loss has plateaued despite reaching a maintenance dose, tolerability is acceptable, and the main goal is greater average weight reduction, Zepbound becomes a very reasonable option to discuss. Plateau at maintenance dose is a different conversation than plateau during titration, and that distinction matters before anyone starts talking about switching. So what should you actually look at when comparing these two? Start with your main goal. Maximum average weight loss points toward Zepbound. Established cardiovascular disease points toward Wegovy. Clinically significant sleep apnea points back toward Zepbound for a completely different reason. And if none of those apply cleanly, the question becomes simpler. Which one can you realistically stay on? Then factor in tolerability, because a stronger drug is less impressive if your body immediately starts negotiating like hostile legal counsel. And factor in access, because a brilliant plan that never gets filled is still, medically speaking, annoying. Zepbound and Wegovy are not just 2 brands competing on the same shelf. They overlap, yes, but they also separate in meaningful ways. Zepbound currently looks stronger for average weight loss in direct comparative data. Wegovy has a cardiovascular outcomes indication in the right population. Zepbound has a sleep apnea indication in the right population. And the real-world choice depends on whether the patient needs maximum average weight loss, a specific labeled benefit, a better fit for comorbidities, or simply a medication they can access and stay on. If your only metric is average weight loss, Zepbound currently looks stronger. If your question is which one fits your goal best, the answer may be very different. That is the difference between watching a comparison video and actually making a clinical decision. Medicine simplified. That's what this channel does. If you want to know more, hit subscribe. This is not medical advice. Consult your doctor.